And when I started, the idea was that it was a disease of the sympathetic nervous system, and I think nowadays we can say that it is an autoinflammatory disease. It's a disease comparable with Crohn, with colitis ulcerosa, and it has many phenotypes. And I will explain to you during the next 20 minutes how we look at it today. This is my disclosure. You also can find it on the website of my university. This is the official definition of the ISP, and I always say it's a complication after tissue damage or surgery. The diagnosis until today is based on clinical criteria. So you cannot send the patient to a lab and get a confirmation of your diagnosis. It's still a clinical diagnosis. And earlier, I think there were 72 names for the disease, so that also gives us a little bit an impression how much we knew about this disease. The diagnostic criteria we nowadays use are the diagnostic criteria developed by Norman Harden and Stephen Brule, and they are now adapted by the ISP as the new diagnostic criteria. And what's important is that there has to be continuous pain, and then they have signs and symptoms in different categories: sensory, vasomotor, pseudomotor edema, and motor trophic. And what's important is that you have to look at the patient and you have to see signs and symptoms. That makes the new criteria much stronger as the old ISP criteria, because in the old ISP criteria it was enough to hear from the patient his symptoms. And I think that bringing in the signs makes them more specific. They also make a distinction between research criteria and between clinical criteria. The clinical criteria are a little bit less restricted. That means that if a patient has CRPS, that the chance that you make a diagnosis is a little bit bigger, but you can maybe understand that if you do research, that you want to have a more specific diagnosis, and that's why they are a little bit more restricted. Also important is that you always have to be intent that there is no other diagnosis which explains the signs and the symptoms. What do we know about epidemiology? There are different studies. One of the studies is of my group, the MOS study. If you translate that to the Netherlands, we have 17 million people. That means that we have 4,000 new patients each year. I think it's a little bit an overestimation. I think that maybe it's somewhere between the study of Sandroni and the MOS. What we saw in the study of the MOS was that it was slightly more in the upper extremity. Fracture was the most common initial event. And as you all know, women are more affected as men. And very remarkable for me was in this study that the mean age of the diagnosis was 52 years. It's are the results of the study, but I've seen patients of all ages. Although I think that CRPS in children is maybe a little bit another phenotype and much more functional as that it is in the more older population. Are there different phenotypes in CRPS? I think you all recognize these pictures, and especially this is what you see in the acute phase. Cold CRPS, there's a blue discoloration, the patient with dystonia, and the patient where you really have to look very good, but which will report allodynia. These are all phenotypes of CRPS. The question if there are different phenotypes was already raised by Stephen Brule in 2002. And what he did was that he looked at 113 patients and he looked at the signs and the symptoms in the 4 domains identified in their criteria. And what they identified was 3 CRPS subgroups, just based on a classification. And that was the florid CRPS, where you see all the signs and symptoms. There was a relatively limited syndrome where especially the allodynia was very prominent, the neuropathic pain, the sensory abnormalities. And there was a group where especially the cold CRPS where the vasomotor signs were predominating. If you translate that to the earlier pictures, then this could be the florid CRPS. This is the CRPS where the vasomotor signs are predominating. And this is the group where neuropathic pain, nowadays we would call it maybe nociplastic pain, with the sensory abnormalities would be the most prominent. What is then the problem with the fourth group? He just studied 130 patients. I think that's a very low number, and we know that dystonia is a rare, prominent sign and symptom in CRPS patients, and I think he just missed it due to the fact that the study was too small. Would it help if you would go from a symptom-based to a mechanism-based therapy in CRPS? Because we know that all those patients are, a part of the patients has a very good natural course, but also a part of the patients has a terrible course. And would it help if you would look in this way and trying to understand the underlying mechanisms to phenotype the patients and to personalize the therapy? For that, we have to go back to the pathophysiology of CRPS. And I just tell you what is known at this moment. And go with me in the flow, don't try to remember all the details, there's no examination afterwards, so don't be afraid, just try to follow my story. You have to imagine that this is a hand, these are the peripheral nerves, this is the spinal cord, and these are the more central parts of the nervous system. And then you can classify, I learned this somewhere in Cardiff on an ISP congress, somewhere in the early 2000s, that you have afferent mechanisms, of which most prominent is inflammation. You have efferent mechanisms, that are mechanisms which originate in the spinal cord. At that time they thought that was the sympathetic nervous system. You have more central mechanisms, and then you can think about, for example, cortical reorganization. Now, let's look a little bit more in detail to this, and let's first focus on what we know about afferent mechanisms. I think it's clearly showed that, especially in the acute phase, there is an inflammatory process. It's shown that the pro-inflammatory cytokines, IL-6, TNF-alpha, are higher in the involved extremity compared to the contralateral extremity. It's also shown that neuropeptides like CG-related peptides, but also substance P, are higher in the acute phase. It's also shown that there is an endothelial dysfunction, and personally I think that's a much more important process as the sympathetic disturbance. Due to this continuing inflammatory process, you get a lot of effects in the periphery. And one of the effects is that there will develop a disbalance between the vasodilating nitric oxide and the vasoconstricting endothelin 1. And this is, in my opinion, the most important reason that you go from a warm CRPS to a cold CRPS. And we see that in a part of the patients, beautifully shown by studies of Anne Oaklander with skin biopsies, that there is a decrease of the small fiber neurons. So there is a small fiber neuropathy developing. And Peter Drummond showed that there is an increase in alpha receptors. And 10 years ago we had a very difficult story where we explained how the sympathetic system influenced that, but Peter very beautifully showed that if you have high TNF-alpha levels, that this induces an increase in the alpha receptors. And this maybe explains also why a patient, if it's cold and raining outside, that they have more complaints. So these are the afferent mechanisms. And you also have efferent mechanisms. And then you have to think about sensory disturbances, motor disturbances, presumably also induced by spinal cord effects. And in the end, there are indications that there is indeed some role for the autonomic nervous system. And then you have more central mechanisms, and in functional MRI studies they showed very beautiful that there is cortical reorganization, but you, for example, also have to think about psychological factors. And I think we did research, we looked at 580 new patients with single fractures, we did a follow-up of 1 year, we specifically looked at the psychological factors. We could not find factors which already were playing a role the moment that they developed the disease. So I don't think that it is a predictor, but when you have CRPS, as in all chronic diseases, chronic pain diseases, you can develop psychological factors. Fear, depression, catastrophizing, etc., etc. So you have to be aware that it's also playing a role in your CRPS patients. But it's important that it's not the cause of the disease, it's a result of the disease. Yeah, one of the very interesting questions is, of course, if you have, for example, a Colles fracture, why one patient is developing CRPS and why other patients are not developing CRPS. And it was already in somewhere in the early 2000 years that Angela Davis from Toronto identified that there is indeed polymorphism in the HLA system on the short leg of the chromosome 6. And what's interesting, this is a polymorphism in the TNF allele, and this polymorphism is also playing a role in other autoinflammatory diseases, like Crohn, like colitis ulcerosa, like rheumatoid arthritis, Bechterew, sarcoidosis are all autoinflammatory diseases. So how can we bring all this information together? How can we make a story of this? And I am aware of the fact that we are still learning every day, and that maybe if you invite me in 5 or 10 years, that I have to tell you a different story, because the story is still building. But on this moment, with what we know, we can make a story, and this story helps us in our daily practice when we look at our patients in our outpatient clinic. The idea is that it all starts with tissue damage. And if it starts with nerve damage, then you call it CRPS2. If it starts with tissue damage, then you call it CRPS1. The normal, natural response of the body is the response of the immune system. And this is due to the fact that you have damaged tissue, damaged nerve tissue, and that you have to restore it. So you will see an inflammatory process after tissue damage or nerve damage. But what's typical for CRPS is that this inflammatory process is running out of control. On the moment that after a Colles fracture you expect that after 5-6 weeks there is consolidation, and then after a few weeks the inflammation, the response to restore the tissue has to diminish. But in CRPS, for some reason, this completely runs out of control. And maybe a genetic vulnerability, comparable with this other autoinflammatory diseases, plays a role. It's also suggested that maybe we are looking at an immune-acquired disease. There is one study who showed that the levels of the antibodies against the parvovirus B12 are higher in CRPS patients than in non-CRPS patients. Personally, I believe more in this genetic vulnerability, but I cannot exclude that maybe it's also an immune-acquired component which is playing a role. Compare it with COVID. In COVID, you are infected by a virus, and what we see is that you get an immune response, and it's in the end not a virus, but it's the immune response who kills you. And what we know nowadays, what we do on our intensive cares, is that we give those patients with severe lung problems after COVID, we give them corticosteroids to lower the response of the immune system. And that's what possibly happens in CRPS. So this inflammatory response runs out of control. And as a result, first one thing, when we did this, the early research in the early 2000s, it was very difficult to estimate that there was an inflammatory response. We made artificial blisters in our patients to measure the higher levels of IL-6 and TNF-alpha. But based on the fact that we now know that it's an autoinflammatory disease, and we made steps for that, we nowadays have a biomarker, and that's the soluble EL2R. The soluble EL2R is also used in sarcoidosis to see at disease activity, and it's also used when they treat the patients with anti-TNF as a marker to look at the success of the therapy. And you also can use it in CRPS patients. So what we nowadays do, if we see a patient on our outpatient clinic, the first thing after estimating the diagnosis is that we send them to the lab and that we ask for the levels of the soluble EL2R. It's a marker for T2 lymphocyte activity. We identified in the meantime a second marker, the CD163. This is a monocyte marker, which also very beautiful rises and goes down with disease activity in CRPS. And this is a paper we just submitted, so that will be available somewhere hopefully in the next year. As a result of this ongoing inflammation, you get an enormous response of your nervous system. And that's the second part of the disease which makes CRPS very special. And because if you look at rheumatoid arthritis, You also will see central sensitization, but you need quantitative sensory testing to estimate the amount of central sensitization. But in CRPS, it's visible. If you look at a CRPS patient, you immediately see that he has central sensitization. And when you have central sensitization, you also have cortical reorganization. Another point is that, and I already explained this, that if you have an ongoing inflammation, that you also get endothelial dysfunction, and in the end this can result in a warm CRPS who goes to a cold CRPS. So this is what I would call the fulminant CRPS. There is inflammation, you can measure that with the soluble DL2, and there is an enormous central sensitization with cortical reorganization, with problems in the motor functions, and in the end, endothelial dysfunction. We know from cold CRPS that in a part of the patient there is still an ongoing inflammation. We measured that with the artificial blister method, and we could measure that also in cold CRPS, that the pro-inflammatory cytokines are still raised in a part of the patients. But what happens during the disease is that somewhere, for some reason, in the majority of patients, the inflammation stops. And what ends is what I would call residual damage. So the inflammation has disappeared, and you can measure it with the lower soluble DL2. And what you see is still in those patients endothelial dysfunction, or central sensitization, or dystonia, or cortical reorganization. And I think that that's the reason why you have these subtypes. So in these patients, you still have, this is the fulminant picture, but in these patients, there is especially the vasomotor disturbance in these patients, especially the nociceptive pain in these patients, and dystonia. Why the disease results in these different subtypes, that's unknown. And of course, you also have mixtures. So you will see patients where there is vasomotor disturbance, but there is also nociceptive pain. But this maybe gives direction to the therapy you want to give. Because if you try to understand the underlying mechanism, then maybe you can make your therapy more personalized. Just another important thing is that in 2019 there was an EFIC Congress, and around the EFIC Congress was in Valencia, around the EFIC Congress there was a meeting of the SIG group, the Special Interest Group on CRPS of the ISP. And for the first time, after a lot of discussion, they give space to the fact that there is CRPS with remission of some features. So there is not a fulminant picture anymore, but you are looking at the residual damage, and that's very important, that not necessarily constitute an improvement. It is especially important for insurance cases, because if you only use the criteria, the diagnostic criteria, and in part of the patients where there is no fulminant picture anymore, they will not fulfill anymore the criteria, but they still have a lot of problems. So and I think that's important that a group like the Special Interest Group makes this statement, because it will also help your patients in insurance problems to give them space that there is still a disease, is still a problem. Okay, what are the constituents for the treatment, if you know all these things? Now, if a patient is referred to your outpatient clinic, then the first thing you have to do is to exclude other diagnoses. And remember the criteria, there may not have to be another reason that this patient has these signs and symptoms. And the reason is that the differential diagnosis of CRPS is huge. If you look at the signs and symptoms, there are a lot of neuropathic pain syndromes, vascular diseases, other inflammatory diseases, myofascial pain syndromes, and even psychiatric diseases who have the same signs and symptoms. So in our outpatient, and we see referrals from the whole of the Netherlands, but also from other parts of Europe and even from the United States, I think that in the end, just about 40% get the diagnosis of CRPS. And in 60% we have another explanation why they have these signs and symptoms. So be aware of the fact that there is a huge differential diagnosis and look very careful at your patients. The second step is to ask yourself which mechanism is prominent. And I can say that all patients have neuroplasticity. This is a typical mechanism in the patient. And what do you have to do for it? You have to start activation and mobilization. Because activation mobilization reduces central sensitization and cortical reorganization. It reduces fear of movement, but it also has a lot of other effects. So it reduces edema, it improves vasomotor disturbances and prevents contractures. So by definition, all our patients receive activation mobilization. If there is inflammation, and you can measure this, send your patients to the lab and measure the soluble EL2, and I'm convinced that in all your hospitals, if you have a rheumatologist, they can measure it, then you know that there is an ongoing inflammation. Then the question raises, what can you do on this inflammation? And the most easy step is to give the patient corticosteroids. And we give all our patients with a higher soluble EL2R, we give them corticosteroids. But we just give them for 10 days, 30 milligram prednisolone, and if that works, and you can measure that with the soluble EL2R, which you also can see it clinically, then you have to think about how to continue, because the problem with high dose corticosteroids is that those have a lot of side effects. A part of those patients you can treat with bisphosphonates, and maybe you will say bisphosphonates, that's something of Kala disease, and that's something which has to do with the calcium metabolisms, but it has very huge anti-inflammatory properties. It takes away the EL6, so it intervenes in the inflammatory process. And of course, one of the things you can do is giving anti-TNF. And in our outpatient clinic, we have several patients, but the challenge is that it's not reimbursed and it's very expensive. But we have on this moment a group of 20 patients where we also described the effects on anti-TNF, and that's also a submitted paper. And I think there is a big future for anti-TNF. Pain. What do you do with pain in CRPS? The problem is that there can be a lot of reasons for pain. If you have inflammation, then I would call that nociceptive pain. If you have central sensitization, then I would call that nociplastic pain. If you have a small fiber neuropathy, remember the skin biopsies of an opener, then you have real neuropathic pain. And then you also can have a special pain, peripheral ischemic pain, based on endothelial dysfunction. So you cannot treat all the patients in the same way, and you have to identify which kind of pain you have to deal, and then make a decision if you treat the patient with analgesics, WHO, or co-analgesics, or with ketamine, which can be very effective for the nociplastic pain. The problem with ketamine is that you cannot give it orally, you have to give it parenterally. But I think there is a strong need for oral NMDA receptor antagonists, and that also would improve the treatment of CRPS patients. What with vasomotor disturbances? You can give a calcium entry blocker, but maybe it makes more sense if you know that the nitric oxide levels are lower and the endothelin levels are higher, that you give those patients nitric oxide. And you can give it in an ointment. There is available on the market an ointment with nitric oxide, so you can give it very locally. And we've published about a case study about patients where we show that this is beneficial. Another way, and maybe a surprising way, is that you also can interfere in the metabolisms in the endothelial system. If you have higher nitric oxide levels, this raises the levels of cGMP. And if you inhibit the breakdown of cGMP, which is responsible for the vasodilating effects, then you, and if you raise the concentrations of cGMP, then you also will see that there will be vasodilation. And you can do that with a drug which is on the market for erectile dysfunction, Tailered, but originally was developed for pulmonary hypertension. And it's very effective in CRPS patients, in the cold CRPS patients. Then the motor disorder. This is a little bit indirect evidence. We know that intrathecal baclofen is very effective, but it's a difficult therapy. There's a lot of challenges in practice. But based on the fact that we know that intrathecal baclofen is effective, it makes sense that you first start with oral baclofen, or you give clonazepam. And if it's very local, but I personally have not very much experience with it, I think it's sometimes very difficult to give botulinum toxin. We see botulinum toxin also on another place, but I will tell you in one of the next slides. But that's the strategy if you have a patient with dystonia. Then the psychological factors, I already mentioned this. It is not a cause of the disease, but it is a consequence of the disease. It is a chronic pain syndrome, so accept it. Also patients with CRPS will have psychological factors which can play a role in the way how they present themselves. And be attentive for it and help your patients if necessary. Then if the therapy is not adequate in this way, and this is, I think, a very disputable thing, and people all around the world will have different meanings. If you go to an INS Congress, they will say, this is ridiculous, you immediately have to start with invasive therapies. We have a very good therapy because we have a neurostimulator, but in the Netherlands we still make this balance between risk and benefit, and that's why we still start with conservative therapy, and if that does not work, then we go to more invasive therapies. But again, maybe there will be shifts in the future, but this is our approach in this moment. And what can you do? You can give sympathetic blocks. You still can give sympathetic blocks, despite the fact that I'm convinced that it's more an endothelial problem as that it is a sympathetic problem. And what's interesting with the sympathetic blocks is that, until a few years ago, this was possible with RF lesions, with chemicals like alcohol. And I was always a little bit that I thought, that's not so attractive, especially in younger patients. But there are now 2 randomized controlled trials who show that there is a prolonged effect with Botox. And that are good randomized controlled trials of good quality, which show that you have at least an effect of 3 months if you do a sympathetic block with Botox. And that makes it much more attractive, because then you do not damage your patients. Now, spinal cord stimulation, I think that there is convincing evidence that spinal cord stimulation, especially in end-of-the-line patients, can be effective. And one of the reasons, I think, is that it is a multi-mechanism therapy. What you've seen in all the earlier mentioned conservative therapies is that they are targeting one mechanism. And the problem in CRPS is that most of the time, multiple mechanisms are playing a role at the same time. And that's what makes spinal cord stimulation so attractive, because we know that it does something on nociplastic pain, on neuropathic pain. It also does something on the peripheral ischemic pain. And dorsal root ganglion stimulation even has effects on the motor disturbance. You are stimulating in the reflex arc, and we've seen patients where dystonia disappears after dorsal root ganglion stimulation. And there are indications not only in animal research, but also in human research, that maybe, but I'm careful, that stimulation also has an effect on inflammation. One of my PhD students did a study where we looked at inflammatory factors, and what we see is that after a period of 3 months of stimulation, you see that the panel of pro-inflammatory cytokines goes to an anti-inflammatory panel. But I'm still careful, because it are limited data, and it also can be that your patient starts moving again, and that also has anti-inflammatory effects. So is it a direct effect of the stimulation, or is it an indirect effect? I already mentioned intrathecal baclofen. Intrathecal baclofen is a good therapy. It's also shown in good studies for the dystonia, but it is a therapy with a lot of technical challenges, and I think that's really something for specialized centers. So that's what I wanted to share with you, and I hope that you take home, not all the details, but that you realize that it's a multi-mechanism disease. I hope that you understand that autoinflammation is one of the most important things at the start of the disease, and that you have a balance with residual damage in the end. And I think that if you phenotype your patient, presumed on the underlying pathophysiologic mechanisms, that can help you to personalize the treatment. Thank you, that's what I wanted to share with you.
Great talk, very comprehensive and updated. Great. Really enjoyed it. Any questions? Question here from Dr. Marshall.
There's a question there first, no? Go ahead.
Thank you for this nice presentation. I want to ask you first about the timing of intervention. If we do intervention early, will it protect from the chronicity of the disease or no?
Yeah, that's a very good question. If they ask me this question, it's not the first time. I always give the example of rheumatoid arthritis. And when the biologicals became available, the anti-TNFs, then they were even more expensive as they are nowadays. And the strategy was start with NSAIDs and then stepwise you go to the end where the most worst patients and therapy-resistant patients get anti-TNF. What you see is that in the meantime a lot of damage develops. And so in the end you have a patient with rheumatoid arthritis with constrictures of his hands, and then they give anti-TNF, and then you see that it will diminish the inflammation, but it will not diminish the damage. So very good question, and that's why it always has to be a dispute. That's why I already said, what is the balance with more invasive therapies like neurostimulation? I'm convinced that there will be a shift because it is a good therapy. But then still, I would prefer to look at if there is an ongoing inflammation with the biomarker, the SOEBL2R. If yes, then treat the underlying problem. And then if you have, and in a very early stage, then apply neurostimulation.
Frank, I think it's an extremely, yes, I think it's a very good idea to take the emphasis off the sympathetic nervous system as a driver of CRPS and think more in terms of inflammation. However, you're stressing inflammation as it is related to the immune system. There's a very different kind of inflammation where the symptoms look quite similar, but the mechanism is very different. I'm referring to neurogenic inflammation, which is a phenomenon that's been known for many, many decades. So the idea here is that if you stimulate a peripheral nerve, and it has to be at C fiber strength, it has to be strong enough to evoke impulses in C fibers, which of course would be painful. What happens is that the impulses, since you're stimulating the middle of the nerve, impulses will go into the central nervous system causing pain. But they'll also go out to the periphery, causing the release of all the various neurotransmitter peptides in those fibers, substance P and CGRP, and the whole bunch of them. And if you keep doing that for a fair amount of time, what happens is you have a breakdown of the barrier between the blood vessels and the tissue. And you have water and other things coming out of the blood vessels and causing edema. And if this goes on for a very long time, and these diseases probably goes on for years, you're releasing these neuropeptides into the tissue which shouldn't be there. Now, you might ask, what has this got to do with this particular condition? Well, I mentioned yesterday, and we've heard actually several points during this session, during this conference, that in some conditions at least, impulses generated in the dorsal ganglion are a cause of pain. And I remind everyone that if we stimulate a sensory nerve ending, the impulses have only one direction to go, centrally. But if there are impulses generated at the ganglion, they will go in both directions. From the ganglion centrally, that will give sensory effects, and from the ganglion outwards, which could cause neurogenic inflammation, especially if this goes on for years. So I think one must consider the possibility that CPRS causalgia, CRPS, it may be related to the same phenomenon of ectopic firing generated in the ganglion over long periods of time, and in susceptible individuals, you're right that this is a relatively rare thing, that this is a second or maybe even the primary cause of the symptoms. And the treatment, or a possible treatment, might be exactly what I had proposed yesterday, of suppressing abnormal activity generated in the ganglion.
I totally agree. In 20 minutes you cannot make it too complex. But we wrote a paper in 2019 where we extensively went into is it autoinflammatory, is it neurogenic inflammation, and there are arguments indeed for both sides of the story, and that's one of the puzzle pieces we still not have the final answers. But thank you for this.
Thank you very much, Professor Heidner, for your. I have a question. Thank you very much for your really excellent presentation. I have maybe a simple, but maybe it's not a simple question. As a general practitioner, I mean, a clinician, that we are confronted with, let's say, quite a lot of acute warm CRPS patients. The first thing we used to do is the sympathetic block, even with long-term local anesthetics on a daily basis, for example. And then the thinking behind this was to reduce the edema. And that is really very quickly. It is reduced very quickly. If you don't do it, you know, it goes on and on. The reason for this was to make, and that's a very important point, I think, to show this, that you have to activate the patient, you know. So active exercises. Now comes my question is, I always advise some people, they're sending the patients to the physiotherapist. That is common. So what the physiotherapist is doing, we do the passive activation. And thereby they are exceeding the pain level, the pain. And I used to advise my patients to do the active exercises. That means not beyond the pain level. Only do this, and if you feel pain, stop. What's your opinion about it?
Thank you for the question. First of all, clinical observations are always very important. So I always listen very carefully to colleagues with a lot of patient exposure, because we can learn from our patients. Second thing about sympathetic blocks, I think that the natural course of the disease is in a lot of patients very positive. So that means that a lot of interventions we did in the past, and you know that in the Netherlands we gave them oxygen radical scavengers, and we did a lot of other things that I think that the patient just improved in the natural course. I've seen a little bit the opposite. What I've seen is that, and maybe you also have seen that, is that sometimes after a sympathetic block, the patient has an exacerbation of his inflammation. And in earlier times we called that an overshoot of the sympathetic block. We didn't understand, but now we know that the pro-inflammatory cytokines can still be higher also in cold CRPS. And it's just a matter of feeding the inflammation. So on the moment that you have vasoconstriction, your inflammation remains limited. On the moment that you open everything, you can feed the inflammation. Not happening in all the patients, but that's another observation. Then about activation mobilization, we learned that also has a very positive effect on our patients. And when this came up, that was somewhere around 2005, that it became very popular but that it really has to be active. So if we select our physiotherapist, then we don't select a physiotherapist where you have to lie on a table and where you get a massage. No, it has to be a physiotherapist where you really mobilize. And that also has anti-inflammatory effects. So and a lot of other effects. So I think that what you've seen in your patients, that's true. And that's why we advise it to all our patients. No matter which phenotype you are, you have to be active. You have to mobilize. That protection. Thank you.
I have the last question.
Yeah.
I also did
many hundreds of patients with CRPS, and in the clinic I always look for, is there still a trigger why the inflammation is gone. So you also have to treat the trigger. Is there a neuroma? Is there a facet pain? Is there something what causes the inflammation? If you treat them both, then you have more success.
Yes, totally true. In the way that what I already mentioned, that just 40% of patients who are referred to us, and we are at third line center, so that means that already a lot of doctors looked at it, and then you would say, who is in doubt about the diagnosis, then we still can say at 60% there's another reason why you have CRPS. So the differential diagnosis is very, very important. Don't be narrow-minded in this.
Thank you for your presentation. What is the role of peripheral nerve block? Any role of peripheral nerve block in CRPS?
Good question. but that's a question where I have no answer. I'm sorry. Maybe there could be a role. Yesterday we spoke about long-term effects of lidocaine, which maybe is also induced by anti-inflammatory effects. But as far as I know, it's just case series, case reports. There are no studies until now. It's a good point.
Shaban, go ahead.
Hi, Professor. Thank you very much for the presentation. I think CRPS is one condition where I feel I failed my patients quite a lot of times. So many treatments we do, they don't work, but I just want to distract the time with what do you think the role of genetics and how do you apply clinically in our patients in the future? Do you think we can target that area and much more optimize our patients? We're coming to patient-centered care, especially for these group of phenotypes. What do you think we should progress and how do you do that?
If I heard the question, if I understand it the right way, then you ask me if I see a role for genetics in the future in CRPS. We have some experience with genetics, with pharmacogenetics, when we apply analgesics. We have in our university hospital a good lab where they can look at the enzymes, but it's still it's still in research settings. For the daily application, I see more in these biomarkers. So these biomarkers, I showed you the SEL2R. I mentioned that we have a second one, the CD163. There is of course a correlation with genetics, but then those biomarkers are very easy to measure, and they really can give you good direction, not only in the diagnosis but also in the therapy. And so it's possible that genetics will be more accessible in the future, but on this moment in daily practice it's far away. And the SEL2R, I'm convinced that also in your hospital, if you remember it on Monday, that you can measure it.
Thank you, Doctor, for your presentation. My question, if already nerve damage back sympathetic dystrophy happened, the effectiveness of sympathetic blockade at this stage, it will benefit the patient. Second question, also, what is the role of medication in prevention, progression of the disease itself? Especially if we are blocking the sympathetic, the patient blood flow is increasing, inflammatory marker decreases, but still the spasticity and the musculoskeletal part of it is not improving, except after aggressive physiotherapy.
So your question is, what is the role of the sympathetic block, and not only on the vasomotor disturbance, but also on the other signs and symptoms of the disease? That's the question, isn't it? Now there will be a direct effect on the vasomotor system. It was the group of Rolf Baron and especially Gunnar Wassner who beautifully showed that, especially in the acute phase, there is a problem, it's a sympathetic problem, but it disappears very quickly. Already after 6 weeks, you see that they cannot show any effects anymore on the sympathetic system. The line center is that you also see the most terrible patients you can imagine, and so we have each year we have 7-8 patients who get an amputation. When there is no skin anymore, when there is a material. And if we did historical examinations in those patients, and then there is complete destroyment of the vascular system. Then you also cannot expect any effect of sympathetic block anymore. And that's also what's seen in studies. From Van Eyck has done a beautiful study, retrospective study, where he showed that sympathetic blocks in the overall population of CRPS just have an effect in 30% of the patients. And that's, so maybe also do it early and not late. Then the effects on the other systems, honestly, I have to admit that I don't know. And that's also a leak in our knowledge on this moment. Interesting, but we don't know, I think. That's the most honest answer I can give you.
Last question.
Is there any role for anticonvulsants in the treatment of CRPs, and if yes, for how long?
There's one study, that's an interesting study. I try to recall the name of the Van der Vussen. It's a Dutch, that's why I remember. He showed that gabapentin is, in a beautiful randomized controlled trial, that gabapentin is effective in CRPS patients. And I'm still a little bit amazed about this, due to the fact that you are targeting just one mechanism, and most of the RCTs which are performed in CRPS who target on one mechanism are negative. So they were in some way very lucky in the phenotype they included. And that's why I think they just included the nociplastic pain patients, the neuropathic nociplastic pain patients, and that's why they showed effect. But if they would have included the whole variety of phenotypes, then that also would have been a negative study. Because in my hands, and then you see the difference between randomized controlled trials and clinical practice. Gabapentin can be effective, but it's not always effective.
It's not always. Thank you. A great talk. Thank you for this session.